Well, at the outset, my special thanks to Dr. Rakesh Gupta and IPCA for the kind invitation. And the case scenario is given to me by scientific committee. A 55 years old patient underwent PCI 3 months back on rosuvastatin 20 milligram per day with the LDL now 25 milligram and triglycerides 72. As you know, LDL is the primary target of therapy in management of dyslipidemia, and statin are the cornerstone of therapy, reducing LDL by 18 to 60% in various studies. The meta-analysis of the statin trial, 23, each LDL reduction of 1 millimole, that is 39 milligram per deciliter, reduce the major coronary events by 23%. And lower the better, as 1% decrease in the LDL reduces the CHD risk by 1%. What the guideline says, the NCP-ATP guideline 2004 endorsed that in very high-risk patients, your LDL target should be less than 70 milligram per deciliter. Same thing endorsed by the ESC guideline 2012, it's 70 milligram, and it is class 1 level A recommendation. But 2013 ACC-HA guideline has abandoned the LDL target and come out with a 4 statin benefit group. One of that in the patients with atherosclerotic cardiovascular disease, what our patient has, and we have to give high intensity statin, which is defined at the statin dose, which reduces the LDL to more than 50%, is the high intensity statin therapy. This is the consensus document by the Lipid Association of India, which has gone a step further and reduced the LDL target to less than 50 milligram per deciliter in the very highest risk group what our patient has. So lower the better. It looks very odd. So higher the better. So statin therapy provides benefits in both the primary and the secondary prevention type of statins that lower the LDL, better is the outcome. Lifelong exposure to the low LDL is associated with the lower CHD risk. Now the question comes, when you are approaching to the lowest level of the LDL, whether it is efficacious or not, and secondly, by doing the lowest level of LDL, will it be safe or not? These are the two areas that we have to discuss. What are the evidence so far the efficacy is concerned? The epidemiological studies showed that the people with a naturally low LDL levels are associated with improved longevity. As you see in hunter-gatherer humans, wild primates, and the wild mammals, they have a normal LDL level of 50 to 70 milligram per deciliter, but do not develop atherosclerosis. What about the efficacy of the lowest level? And we have data from the two landmark trials, the PROVE-22, the sub-study, and the Jupiter post-hoc analysis. In the PROVE-22, among the patients who sustained an ACS, the highest level of the risk reduction occurred when the LDL fell below 40 milligram per deciliter. And the same study showed that when you are approaching the when you are targeting the less than 40 milligram per deciliter, the death, CHD death, myocardial infarction, any stroke, and the primary composite endpoint substantially reduced as compared to the other target levels of more than 40, 60, 60 to 80, and 80 to 100 milligram per deciliter. And this is from the this post-hoc analysis of the Jupiter. Less than 50 showed a better outcome as compared to more than 50 milligram per deciliter. And in the same study, rosuvastatin 20 milligram in patients with elevated high CRP, achieving the target of less than 50 milligram per deciliter, there was a 65% reduction in the risk of cardiovascular events and 46% reduction in the total mortality. And it has been observed in all subsets of the patients. Based on these data, this PROVE-22 and the post-hoc analysis of Jupiter, is there any need for the re-evaluation of the NCP-ATP3 guidelines, which endorse that it should be less than 70 milligram per deciliter? After achieving the LDL target to ultra low level, the rate of death or cardiovascular events continue to drop lower and lower, suggesting that a target level of LDL less than 70 milligram per deciliter might not be the lowest target as per the NCP recommendation, and therefore there should be rethinking of the LDL treatment targets by the NCP-ATP. And India has gone a step further. They already endorsed that it should be less than 50 milligram per deciliter in very high risk group. And this is the paper we showed that an LDL-C of 57 milligram per deciliter for primary prevention and 30 milligram per deciliter for secondary prevention would be sufficient to achieve a cardiovascular event rate of 0. Coming back to our patient, does lowering of LDL to ultra low level, that is 25 milligram, provides an additional benefit? And we have data from the PCSK9 inhibitor trials along with a statin. What are the evidences? And the evidences come from the ODC long-term study with eluricomab, where 25% of the patients, they achieve the target of less than 25 milligram per deciliter. And when you look at the duration of exposure to LDL less than 25, it is almost 52 weeks. And it showed a substantial reduction in the cardiovascular events with a hazard ratio of 0.46. In the next Fourier trial with evolocumab, which clearly showed that 42% of the patients, they achieved the target of less than 25 milligram per deciliter with a substantial reduction in the cardiovascular events. The primary endpoints reduced by 15%, secondary endpoints reduced by 20%, and we have gone a step further with this trial. The 5% of the patients achieved an LDL level of less than 15 milligram, and 2% of the patients, they achieved even the LDL of less than 10 milligram per deciliter. Those who achieved the level of less than 10 milligram had a more than 40% lower risk of CV events than those with an LDL cholesterol equal to or more than 100 milligram per deciliter. Now coming to safety issues of the lowest level of LDL, and this question has been raised by the few based on the J-curve hypothesis with the argument that the total mortality can be increased due to the disease processes like cancer and intracranial hemorrhage. But when you look at the data from the cholesterol treatment trialist meta-analysis, there is no safety signal so far the cancer is concerned. It is almost comparable to the placebo. And when you look at the intracellular hemorrhage, the meta-analysis of 23 randomized control trials clearly showed no risk of the lowest level of LDL. And statin in cognitive dysfunction, this is non-randomized control trials. That is data from the 7 observational study again showed no risk of cognitive dysfunction with achieving the lowest level of LDL. And this is the data from the PROVE 22. When achieving the target of less than 40 milligram per deciliter, the hemorrhagic stroke is not increased, and it is almost comparable with the 40 to 60 target, 60 to 80 target, or 80 to 100 target. And muscle symptoms are also not increased with achieving the LDL of less than 40 milligram per deciliter. And these are from the Jupiter trial. The incident cancer death, and the hemorrhagic stroke almost comparable with placebo. And here again, the less than 50 and more than 50, no difference so far the adverse events are concerned. Now coming to the safety issues, when you are achieving the LDL of less than 25 milligram, what our case scenario is there. The Jupiter trial clearly showed the rate of adverse events in those with a LDL of less than 30 milligram per deciliter on a statin was low. However, there was a modest increase in the diabetes and hematuria in patients with LDL of less than 30 milligram. No significant difference in the memory impairment also in the patients achieving the LDL of less than 30 milligram with the statin therapy. This is again from the Jupiter post-hoc analysis. And this is the improved data so far safety is concerned. Less than 30 milligram, no safety signals are there. Very recently, a pre-specified safety analysis of the IMPROVE-IT involving more than 15,000 patients showed that the patients with the LDL level of below 30 milligram per deciliter had no increased adverse events over 6 years follow-up. And this is the Osler data, which also showed that evolocumab, the LDL less than 25 milligram, showed no safety signals so far adverse events are concerned, and no safety signal again when LDL is less than 25 milligram in patients with 12-month evolocumab trial. The other trials are there. The ODC long-term trial also showed that when the patients achieving the target of less than 25 milligram, there is no safety signal so far adverse events are concerned. And same thing when they achieve the target of less than even 10 milligram, there are no safety signals so far PCSK9 inhibitors are concerned. And this is the statement by the Steven Nissen that there is never been any evidence from any clinical trials showing a hazard of a very low LDL cholesterol level, and it's hard to argue that we should reduce the dose of statins simply because the LDL is very low. Recommendations: several studies indicate that a decrease of LDL to level of 40 to 60 milligram reduce the atherosclerotic cardiovascular disease, and it is safe. Some studies indicate that the reduction of LDL to even below 25 milligram is safe and it reduces the atherosclerotic cardiovascular disease. But the published studies only have followed patients for 1 year. More time will be needed to determine whether the LDL reduction to less than 25 milligram can be recommended. So take home at the end, CVD events and the IVUS data clearly showed the additional benefit from the low and the ultra low levels, that is 25 milligram per deciliter of the LDL. A growing body of evidence suggests that LDL level can be safely driven to very low levels in individuals at a high risk of atherosclerotic cardiovascular disease. They do not show increase in the clinical and the lab side effects compared to the control or those with a high LDL. And based on the current evidence, the real safety concern is under treatment of LDL rather than very low LDL. So lower the better. So in our case scenario, in this case scenario, there is no confusion at the end. Continue the same dose of rosuvastatin for the longer term, because I have shown the data in favor of the lowest is the better, more reduction in the CV events, and there are no safety concerns. Thank you very much.